I'm going to talk about skin cancers, melanoma specifically. Even though it says ASCO, there are a couple of other, I think, relevant updates that I want to share with you. These are my disclosures. And just want to remind everybody that, we have come a long way in melanoma. Since 2011, there are multiple new drugs that have been FDA approved. On the left-hand side, you can see all the immunotherapy drugs, Ipilimumab, Pembro, Nivo, combination of Ipi-Nivo, and intralesional TVEC. On the right-hand side, you can see all the molecularly targeted therapies, 3 different BRAF inhibitors, and 3 different combinations of BRAF and MEK inhibitors. Just focusing on immunotherapy first. So this was a pivotal trial which compared PD-1 Nivolumab specifically to Ipilimumab, and then also had an arm of combining the 2 drugs together, Ipi plus Nivo. Ipi was at the dose of 3 milligram per kilogram given every 3 weeks for a total of 4 doses in the combination, followed by Nivo maintenance. And what this trial clearly demonstrated is that PD-1 drugs, either alone or in combination, work remarkably better as compared to Ipi. The response rates are much higher, and especially for PD-1 monotherapy, the toxicity was less as compared to Ipi. So PD-1 monotherapy was a win-win over Ipi, both in terms of effectiveness as well as toxicity. And then if we use the 2 drugs together, we get even better efficacy with higher response rates, but that comes at the cost of significantly increased toxicity, as you can see here by the rate of grade 3 or higher immune-related adverse events. So there is some long-term data on this trial that was published last year. This is showing survival at 5 years. So the top curve is Ipi-Nivo, and Nivo alone is shown in the blue here. What you can see is even though this trial was not quite powered for comparison between these 2 arms, you can see that the curves have separated. There is a numeric difference, at least 8% or so, which is not trivial. 1 in 10 melanoma patients or 11 melanoma patients is going to be alive on the combo as compared to the Nivo if everybody was treated on that arm. So I think it suggests that the higher level of immune activation that we are getting with the combo is contributing to somewhat better outcomes. And this is the only trial that we have which is trying to answer. So we are going to be stuck with this data. Now, both these arms again are much better than Ipi, so there's no reason for us to use Ipi, PD-1 based therapy, either monotherapy or in combination, depending on how a patient is perceiving the toxicity of the combo is, I think, the current standard of care. Now, what we also know that immunotherapy does not work all the time. If you look at the waterfall plots here for both Pembro and Nivo, there is a substantial proportion of patients who does not have any regression of their tumors. And obviously we need more therapies for these patients. Now, fortunately, if we have the BRAF mutation present, which happens in close to 60% of melanomas, we have the activation of the MAP kinase pathway, and in the subset we can use either BRAF inhibitors alone or BRAF plus MEK combo that is FDA approved. Oops, sorry about that. Okay, so now the remarkable thing about BRAF inhibitors is that the vast majority of patients experience tumor regressions. There's a very, very small proportion of patients who do not experience that. So BRAF inhibitors are very reliable in the subset of patients who have the BRAF mutation. Now, BRAF inhibitors typically do not work for a long time. As you can see, the progression-free survival curve is here. The vast majority of patients have experienced progression in the first few months. The median progression-free survival with dabrafenib trametinib was close to 9 months or so. So resistance develops at some point. But this was a long-term follow-up on one of the pivotal trials, which suggests that there is a small proportion of patients who can actually become long-term survivors without progression on BRAF/MEK inhibition. The proportion is low, only 19% at 5 years, but nevertheless meaningful. Now, one big distinguishing factor here as compared to immunotherapy is with immunotherapy, we get a much higher proportion of patients who are progression-free at that time point. And also, most people are not continuing to get immunotherapy treatment for that long. But in this trial, the vast majority of these patients were still continuing on BRAF/MEK inhibition at the time of this follow-up. So, again, we are forced to answer this question as to which modality is better in patients who have the BRAF mutation. Should we be using BRAF/MEK upfront, or should we be using immunotherapy upfront? And this is a cross-trial comparison, so it's not really a randomized trial, but I think it highlights some of the key characteristics of these therapies that we tend to see in our clinic as well. So response rates are very high for both these regimens, maybe a little bit higher for BRAF/MEK, as I showed on the waterfall plot as well. When it comes to the complete remission rate, quite comparable. But the real difference here is progression-free survival and overall survival, which favors more the immunotherapy arm. And as I mentioned earlier, with immunotherapy, you do a defined duration of treatment. And once you get a response, or after a couple of years, generally in most trials, people have stopped immunotherapy. So in this trial, only 11% of patients were continuing to get treatment, as compared to the BRAF/MEK long-term follow-up, where 88% were still on treatment. So the bottom three rows here would suggest that we are probably getting better long-term outcomes with immunotherapy, although that has not been proven in a randomized head-to-head trial. So what do the NCCN guidelines state right now? Again, the preferred regimens are PD-1 based, either use anti-PD-1 monotherapy or Ipi-Nivo combination. And appropriately, they mentioned that yes, BRAF targeted therapy is also acceptable and probably preferred if clinically needed for early response. So somebody has bulky disease, about to cause impending liver failure, or big tumor compressing on the spinal cord. We don't have time to waste in those situations. We need a response right away, and in a much more reliable way. And in those situations, it will be more appropriate to choose BRAF/MEK first. But if we really are looking for long-term responses, I think we have a better chance of getting those with immunotherapy. So that's kind of where we are right now in the field. And there are quite a few questions that we still need to answer. And some of the studies that have been presented this year try to attempt to answer those. So the first question is, how do we optimize frontline therapy for metastatic melanoma? And this was an interesting study. As we talked about, Ipi-Nivo combo has a considerable amount of toxicity. We typically would be doing this combination with 4 doses given every 3 weeks, the induction phase. And then at 12 weeks, we would transition to Nivolumab monotherapy if a patient is doing well. So this study is a single institution study at Memorial Sloan Kettering, and it was asking the question of how to optimize the number of doses with the Nivo-Ipi. So the design was actually very interesting. So Nivo is given again at 1 mg per kg, Ipi is given at 3 mg per kg. You do 2 doses every 3 weeks, and at week 6, they did a scan, and depending on the scan results, if there was continuing tumor growth, patients would continue to get 2 more additional doses per the standard schedule. But if you had evidence of regression or stable disease, then instead of pushing 2 more doses, which could result in more toxicity, they said, well, let's transition proactively to maintenance Nivolumab and see if it can strike the right balance between toxicity and efficacy. So these were the results. So at week 6 scan, 2/3 of the patients were actually responding in some way. Either they had regression or mostly stable disease. And 1/3 of the patients had clear progression as they defined here by tumor burden growth more than 4%. So essentially no stable disease or response, not by RECIST, but just clinical assessment of whether the tumors are growing or not. And what they noted was that amongst these 19 patients, none of them had subsequent RECIST responses. And this is what happened on the trial at week 6. You see patients who have responses, and some patients have stable disease and some have progressive disease. And if you look at week 12, there are a few more patients who develop responses, and then a few more patients who are developing progressive disease. And these are all likely coming from patients who have stable disease at week 6. So some of those stable disease patients end up becoming responders, and others may develop progressive disease. So what does this signify? Again, we know that PD-1 responses are generally quicker. Responses that are coming from Ipi, because Ipi is involved in antigen presentation and priming of the immune system, takes some time. So typically we see more delayed responses with Ipi. So it takes time for Ipi responses to mature, and you can sometimes even see pseudo progression. So maybe at week 6, some of those patients who have stable disease, there is a chance that they may actually become responders. And I think it's important to let that play out, because we don't want to stop a therapy prematurely if it has some chance of responding. Now, the main reason for optimizing this regimen was, if you stop the combination treatment after 2 doses, maybe you will get lesser frequency of high-grade adverse events. Now, they did not actually report the immune-related adverse events by each arm on the trial, but the overall incidence was not significantly decreased here. It's very comparable to what we have seen in phase 3 trials, despite the fact that 2/3 of the patients got only 2 doses of the Ipi-Nivo combination. So my conclusions on this study is that an early restaging scan at 6 weeks, I think, is somewhat predictive of the final outcome. If you see major regression at 6 weeks, I think you could possibly use this data to make an early switch to maintenance therapy. I don't think that would be considered unreasonable. And maybe in those patients, you could avoid significant immune-related adverse events, and you may not have to use steroids, and hopefully you can preserve those good outcomes that way. But if you're seeing clear progression at 6 weeks, so progressive disease, the chances are that those patients are not going to have a dramatic response down the line. So especially if that progressive disease seems to be threatening clinical safety, I think this data will support that you proactively want to switch to another approach. And for example, if you have the BRAF mutation present, you could switch to BRAF MEK inhibitors at that time. And just a caution, we have a small number of patients from single institutions, so that definitely limits generalizability of these results. But nevertheless, I think it gives us additional insights into the kinetics of response during the Ipi-Nivo combo, which is typically done at 12 weeks restaging. And now, that early look might actually be helpful in the clinic. So there are other ways of optimizing the combination too. There was a BMS-sponsored Checkmate 511 trial, which looks at an alternative dosing of Ipi. So the standard schedule is again in the green here, Nivo 1, Ipi 3, but they compared this to Nivo 3 and Ipi 1. These are the results. Essentially, the response rates were very similar in the 2 arms. If you look at the waterfall plot, again, qualitatively look very similar. If we look at the progression-free survival and overall survival, almost identical. Now, interestingly, if you use a lower dose of Ipi, you actually get less toxicity. So the grade 3 or higher adverse event rate is 33% as compared to almost 50% with the Ipi3 arm. So this trial suggests that by using a lower dose of Ipi at 1 mg per kg, maybe you can still preserve the efficacy of the combo, but at the cost of, the cost in terms of toxicity may be closer to the PD-1 monotherapy as compared to the conventional Ipi-Nivo dose. So, that was, that was the frontline immunotherapy. The other burning question in the field is that if you do have the BRAF mutation present, can you combine BRAF targeted therapy with immunotherapy? And this trial is a phase 3 randomized trial, which is looking at one specific BRAF MEK combo, vemurafenib, cobimetinib, and combining it with a PD-L1 inhibitor, atezolizumab. And this is the IMSpire 150 trial. And these results were presented at AACR and just recently published in Lancet as well. So this trial, again, it was a randomized trial, Vemu, Kobe, a lead-in phase, and then PD-L1 inhibitor was added. I think one nuance here is that in the triple combo arm, the immuno-targeted therapy arm here, they used a slightly lower dose of vemurafenib at 720 BID as compared to the full dose here at 960. Not sure if it mattered, but most patients in my practice end up settling on this dose anyways. So the progression-free survival curves are actually separating quite well here. So the top arm is the triple combo with immunotherapy. And you can see, 43% versus 31% progression-free survival at 18 months, favoring the immunotherapy arm. This is the duration of response. Again, the responses are durable in both groups, but more so in the immunotherapy group, suggesting that immunotherapy might lead to more durability. Now, interestingly, the overall response rate is similar in both groups. And this is probably mostly driven by BRAF MEK because BRAF MEK works right away. So most of these tumors are going to respond early on, but the duration of response, again, favors the immunotherapy arm. Overall survival, not much difference at this early look, some numerical separation, but I think it will be important to follow up for longer and see what happens. So adverse events are actually very interesting. We were talking about chemoimmunotherapy in the lung cancer arm, and on this trial, it highlights some of the challenges when you're combining multiple therapies. It may be hard to tease out what's coming from immunotherapy, what's coming from targeted therapy. Even though numerically, most of these categories were comparable and there were some minor differences, what was most interesting to me was that the steroid use was quite high. With PD-1 monotherapy, we would expect steroid use to be around 20% or so. But if you look at just the Vemu plus Kobe arm, 51% of the investigators use steroids. And these could be for things like, AST, ALT increase. And when that happens, instead of, blaming it on the targeted therapy, you might be saying, oh, maybe it's immune-mediated hepatitis, let's use steroids. And it's possible that inappropriate steroid use might have compromised outcomes in the BRAF MEK group, possibly. So it's as we start using more combinations, I think it's going to be more critical to tease out where the side effects are coming from. So by the way, this combination was, I think, given some conditional approval by the FDA. I haven't used it outside of a trial yet, but the obvious question then is, how do we use this data in our practice? Again, just a reminder, with BRAF MEK alone, very few patients become long-term survivors. Now, in this trial, the population, 32% progression-free survival at 18 months. So suggesting that, the results might be comparable to what we would see with BRAF/MEK therapy. But if you look at immunotherapy comparison, again, across trials, with the triple combo, the progression-free survival was 43% here at 18 months. And if we look at the immunotherapy curve here, it's 36%. So again, these curves are probably going to drop down, and the really long-term progression-free survival is important to see, are we truly getting durable responses with the immunotherapy? So my conclusions on this trial is, yes, the triple combos definitely appears to be improving progression-free survival as compared to BRAF/MEK alone. OS data is still not mature, but I think it might be pointing towards superiority. We'll see. Toxicity appears to be manageable, although, as we talked about, steroid use could be higher than anticipated in both arms. Ideally, this trial should have had an immunotherapy only comparator as well, because that's what most clinicians are currently using in the frontline therapy. So how am I going to use this data? I don't think it is strong enough for me quite yet to say that this triple combo is better than immunotherapy, which is my current practice. But there are some patients where I am using BRAF/MEK. Those are the patients where we need a response right away. And if I am using BRAF/MEK in those patients, why not use this data to add PD-1 on top of them to try to get more benefit? So that's kind of how I am thinking about this data at this time. Now, interestingly, a few weeks after that promising data was published, another company's data, which is also looking at their own PD-1 with their BRAF/MEK, and they did a phase 3 trial, and this is just a press release that they did not meet their primary endpoint. So one trial is positive, another one is not. I think that raises questions, and obviously we need to see more data on this particular combo. So let's see, how are we doing on time? Okay, so I will go over PD-1 refractory melanoma real quickly, because that's very relevant. When we are using these drugs, not all people are responding. As we know, there are patients who have intrinsic resistance. That means they never respond to begin with to these drugs. And then there are some patients who progress slowly over time after an initial response, and these are the patients with acquired resistance. So we definitely need more treatment options for that group. There were 2 abstracts that looked at the question of people who get PD-1 monotherapy and do not respond. Can we use Ipi down the line and salvage a proportion of those? So this was a multi-institutional retrospective look at patients who got this approach. And I won't spend too much time over it because it's retrospective, although it does have quite a large number of patients. So the results are, I think, somewhat insightful to what we already do in the clinic. Again, not going over too much detail on the comparison between different groups. This was not a randomized assignment. These are patients presented, and clinicians chose whether they are going to get Ipi plus PD-1 or just Ipi alone. But when we look at it retrospectively, it seems to favor that people who are getting Ipi plus PD-1 seem to be doing better as compared to who are getting Ipi alone. Now, there could be all sorts of selection biases here. Maybe the patients who have better performance status are thought to be more of candidates for the combination therapy. And indeed, if we go back, we did see that if ECOG PS greater than or equal to 1 was much higher in the Ipi only group as compared to Ipi plus PD-1. So this is overall survival. Toxicity, interestingly, was comparable in both arms. Again, this could be because we have patients who have already had PD-1. Somebody who had really bad side effects are probably not going to be eligible for more immunotherapy. So we are kind of weeding out the bad actors in terms of toxicity, and IPI use will probably contribute to some toxicity, but may not be very different from whether you use IPI plus PD-1 or IPI. So these are the conclusions from this retrospective review. So IPI combined with PD-1, they suggested has a higher response rate and similar high-grade toxicity. This is actually a prospective trial looking at the same thing, low-dose Ipilimumab, 1 mg per kg with Pembro following progression on PD-1 antibody. It was a small phase 2 trial, 70 patients. Pretty representative of the population that we see in the clinic, with a good proportion of M1C patients, some patients with brain metastases, liver metastases, and the waterfall plot suggests that IPI addition to PD-1 does seem to work in a proportion of patients, as you can see from the tumor waterfall plot here. Toxicity, again, more comparable to IPI monotherapy, around 20% or so, much lower than what you would expect with IPI-Nivo combo in the frontline setting. This is an interesting plot here. So on the right-hand side, you can see the swimmer plot, how are patients doing on this trial, again, suggesting that responses to IPI can be very durable. Now, what they looked at is how are these patients doing on prior PD-1 therapy? One could anticipate that somebody who had a good response to PD-1 previously is more likely to respond to IPI, in which case, you would have had a distribution similar to the right-hand side on the left-hand side, but they did not see any obvious correlation. So regardless of what kind of response you're having on the prior PD-1, you have, some chance of responding to Pembro plus IPI. The rate of response is low, but again, reassuringly, responses are durable, suggesting that immunotherapy, when it works, it can work really well. So conclusions, this is the largest prospective study so far of a PD-1 plus IPI combo, which demonstrates activity. And the combination had a response rate of 27%. And treatment-related grade 3 toxicity occurred in a quarter of patients. So Pembro plus low-dose IPI can be effective in non-T cell inflamed tumors, is what the author's conclusion was. My conclusion is IPI monotherapy or in combination with PD-1, I think it can be an effective salvage therapy in a proportion of patients with PD-1 refractory melanoma. Response rates are low, responses tend to be durable. Toxicity rates may be similar with IPI monotherapy or IPI PD-1 combo in this setting. And NCCN guidelines for second line or subsequent therapy recognize these data. So preferred regimens are anti-PD-1 monotherapy or Nivo plus IPI combo, or combination targeted therapy if BRAF mutation is present. And they also talk about some other regimens that we can use, IPI monotherapy or high-dose IL-2. Now, I do have some slides on neoadjuvant therapy, but I'm actually going to skip those in the interest of time. And maybe what I can do is actually just leave you with my conclusion slide on neoadjuvant therapy, because that's a really hot topic right now. So just bear with me for one. Okay, so I think neoadjuvant therapy definitely is feasible and potentially promising. I think what we need to do in many of our trials is we need to define the goals of therapy upfront. Are we going to reduce surgical morbidity by using these therapies proactively? Or maybe avoiding unnecessary systemic therapy down the line? And then I think the real question is, before we start using neoadjuvant therapy routinely, we really need to know whether neoadjuvant administration is going to be better over our standard approach, which is surgery plus adjuvant systemic therapy. And the question of whether we should use BRAF inhibitors versus immunotherapy in the neoadjuvant setting is also highly relevant, similar to metastatic and adjuvant setting. So I think I will stop there, and thank you very much. And let's take any questions.
Dr. Bhatia, can you just list the abstracts that you were going to discuss in the neoadjuvant, and we can read those on our own?
Absolutely. I think we can make these slides available. We can email these slides out too, and this.
Okay, that will be great.
Yes.
Thank you.
So Shailender, we have a question by Dr. Brahma Konda. What is the mechanism of resistance in patients who fail or progress after initial good response?
So that's a great question. So, there are a lot of people are working on mechanisms of resistance to immunotherapy. And, there's what's emerging out is there's no one unifying mechanism. So what we know so far is there are tumors that look that seem to be, so-called hot tumors, rich with immune cells in the tumor microenvironment. Those are the tumors typically have PD-L1, good PD-L1 expression, CD8 T cell infiltration, and those are more likely to respond to immunotherapy. And those may also respond better to PD-1 monotherapy, and maybe you're not getting as much benefit from combination therapy in that situation. But what we know is those kind of tumors are not that prevalent. Despite having a high mutational burden, we don't have as high of a proportion of hot tumors as we would want. We still have, the majority of patients have cold tumors, and the mechanisms of immune evasion in those cold tumors are, represent a very broad portfolio there of mechanisms. Either, the antigens are not expressed and the tumors are just not visible to the immune system, or there are alternative mechanisms of exhaustion of immune cells. But that's really the burning area for correlative research right now. And, we hope to learn more, and, many of our trials are now targeting those specific mechanisms in those subgroups where we are lucky enough to find those.
Another question by Dr. Shobha Mandal. If we see pseudoprogression, should we stop treatment?
Well, that's an interesting question. So, if we know it's pseudoprogression, then we should not stop treatment. So generally, the dilemma in the clinic is that the tumors are progressing. We don't know whether they are truly progressing or whether that's apparent progression from inflammation due to immune cell infiltration and so on. So my approach is, if the patient is in a time point where we still have a chance of response, then we ask ourselves the question, is it safe to wait for a few more weeks and let it play out, confirm the progression before we suspend a therapy that might be working? But what the first study showed was, there are some patients who may have progression or stable disease and could go on to have responses down the line. Now, but if you have clear progression, everything's exploding, it's very unlikely that you will get a response down the line. So especially progression that's threatening clinical safety, it's okay to move on. If it is clinically stable, mild progression, something's increasing in size or something new has appeared but not threatening, I think we should play it out a little bit more.